So welcome everybody. Come on up to the front. We're going to have like a fireside chat with no fire. I wish I had one because I'm freezing. But so I'm going to just talk about how we're managing anaplastic thyroid cancer right now, because a lot of these things are actually not in the guidelines. Okay, so I know I'm on the guidelines committee for ATA, but I don't agree with everything that's in the guidelines, and so this may not completely jive with what's there. But this is how this is our current management of ATC. I don't think I need to go over this slide. Basically, has the worst prognosis of the thyroid cancers. It's very rare, and so a lot of people don't know how to treat it. And about half of patients, when they present, they already have metastatic disease, and it's very rare to have a tumor that you can actually remove without, doing like removing the voice box or doing anything very radical. Okay. The staging is very simple because they're all stage 4. What is staging? So staging is just a way for us to think about what is the risk of the patient dying from that cancer. And because anaplastic is so aggressive, they're all stage 4s. And then we subdivide those into A, B, and C. And so it's really important to understand, right, that these have a different prognosis within themselves. So a 4A is very different from a 4C. A 4A is a patient where it's kind of an oops. They took them to surgery, and lo and behold, the pathology shows anaplastic. It's almost always that way. You almost never take out a 4A knowing that they had anaplastic. Okay. So those have a very different prognosis from the 4Bs and 4Cs. 4Bs have disease that's left the thyroid gland, but it's still in the neck. And then 4Cs have disease that has it left the neck. It's now in other places of the body. And the problem with this disease, the 4As generally do pretty well. Okay. The problem, but they're very rare. The 4Bs, the problem is that even when you give them the standard treatment, which was radiation and chemotherapy, about half of them, about 3/4 of them are going to end up with either their tumor in their neck growing or new tumors somewhere else in the body, right? So we don't think of 4B patients as having like, it's much better than 4C because they both have a pretty, these are pretty aggressive tumors. Okay. But the new thinking is that we not only think of these patients as A, B, and C, we also need to think about them whether they have a BRAF mutation or not, because that determines your prognosis, because we have good therapies for those patients. And this slide just shows that. So I don't know if you understand what these curves are. Does anybody know what this means? No, right? Like, yeah, most people don't know what it means. So these are survival curves. You want to be at the top of that curve. You want to be up here, okay? Ideally up here, because that means that you're going to be alive at 5 years, right? You don't want to be the one down here. Okay, those have the worst survival. Each time this ticks down, it means that the patient has died. Okay, so how do we get these patients up here and these patients way up here? Okay, I think we can do that. But this is what we're looking at, currently, is that the BRAF mutated patients do the best, the RAS mutated do the worst, and then the in-between patients are in between. Like NF1 mutated and other things. So the guidelines, the great thing about the guidelines is that really have clarified now. So if you look at the 2012 guidelines, it was the saddest thing you would ever read. In fact, don't read them because they were incredibly depressing, basically said that like most patients just needed to go to hospice. And in these guidelines in 2021, now they're to me outdated. So things move fast. We no longer are thinking of patients as, everybody has to go to hospice. We now want to understand what is your stage, what is your BRAF status, and then we can have a conversation about your prognosis. And every single patient, the other great thing about the guidelines is that every single patient, doesn't matter if you're stage 4A, A, B, or C, needs to have mutation testing. Absolutely needs to have mutation testing. It's no longer acceptable to just send a patient to surgery or radiation or put them on chemotherapy without knowing what their mutations are. So I'm going to talk about these different strategies that you've heard in other sessions by now, because I've been to a few of them, the neoadjuvant, the immunotherapy, and then combining therapies. Okay. This is not moving. There we go. Okay. So personalizing therapy. In 2011, we didn't really know how to manage this disease very effectively. And so everybody got this one size fit all. It's very cookie cutter. Everybody got surgery, radiation, or chemotherapy. In 2014, we made kind of this leap of faith and said, okay, what if we start treating patients based on this mutation, which was really kind of the, pretty common mutation about 40 to 45% of patients had, which is the BRAF mutation. And so that kind of really changed the entire field. And if you went to see Dr. Haugen's talk, he said that he didn't think that was going to work. And I have to tell you the truth that I didn't think it was going to work either. Okay, but we had nothing else that was working, so we tried it. The major problem with this strategy is that having to do the mutations, having to know the mutations takes time, right? And so we faced this problem that, okay, we had a trial now, but how are we going to figure out who has a BRAF mutation fast enough to treat them before they get really sick? Okay, so this is what we did. We really focused on trying to figure out very quickly if patients had a BRAF mutation, and we did that. You can do that in 3 ways. One is to just stain a slide. So it's kind of like with breast cancer. If you have breast cancer, they divide patients into ER, PR positive, and if you express the estrogen receptor, and every single slide is stained for estrogen, to see if you have a different type, these different types of breast cancer. It's kind of the same thing. You can stain the slide to see if you have a BRAF mutation. And so that was a very fast way. It takes about 24 hours to get a result. The PCR test is also a 24-hour turnaround. And then we have a liquid biopsy test, which also was talked about a little bit, that's the liquid biopsy we were talking about earlier, where you can take the blood, separate out the plasma and find fragments of the tumor DNA. And then you might be able to find the BRAF mutations or other things like fusions this way. And so this is a very easy test to do. Payers now are paying, thank goodness. And the only problem is that the test currently takes about 7 to 10 days. We're working on a test that takes just a couple of days now. And that's now buried in the 2021 guidelines, but it is there for liquid biopsy. Okay, so this is the recommendation from the ATA, which is basically, you need to consider doing very rapid BRAF testing. So that was a big win for us because we got that into the guidelines. And then every patient has to have a molecular profile. Okay, so what do we do for stage 4A and for patients who don't have a BRAF mutation but have 4B? Okay, those patients get upfront surgery if they can have surgery and radiation. And so this is our, we're actually going to publish this hopefully soon, which is basically our own guidelines of how we manage these. But basically you just ask, okay, can you take it out? If you can't take it out, then you go to radiation and you also get chemotherapy. If you can take it out, then you get chemotherapy and radiation. But the problem is that addresses the neck pretty well. The problem again is that, 3/4 of the patients are going to fail that treatment. And so that's still a very high risk situation. And because of that, we treat patients with pembrolizumab with immunotherapy after that, the radiation is completed. So that's why it says MD Anderson trial. We're doing it on a clinical trial. We have patients that are also not on the trial that we're doing it on who came before the trial had opened. So that's something that differs from the guidelines. Okay, so targeted therapy for anaplastic thyroid cancer. So you have to understand that these tumors come from differentiated thyroid cancers. So these tumors start out as a papillary, for example, right? We're gonna start with papillary, which in papillary we see 60% have a BRAF mutation. They sometimes are high grade papillaries. They can become less differentiated and become poorly differentiated, and then anaplastic thyroid cancer. So, but the BRAF mutation stays with the tumor the whole time. It doesn't matter, right? So if it came from a papillary, it's going to be, if it turned into an anaplastic, it's still going to have that mutation. And that holds true for all the other types that aren't listed on here, but follicular derived ones. So patients that had follicular thyroid cancer and it turned into an anaplastic and they have a RAS mutation, maybe that RAS mutation stays. And same thing with Hürthle cell. Okay, so this was that first study, and I know you guys all want to know who these 4 individuals are. I'll tell you that it does not matter who they are, because it's great to be on a waterfall plot that shows that you've had a complete response, but really what you want to do is live longer, right? Don't you want to see your grandchildren? Yeah. Exactly. So it's great to be patient 1, 2, 3, and 4. But the reality is that you really, what you want is to be this person here that has not died, right? And those 4 people are not necessarily these 4. So I know everybody's fixated on the blues. This blue line I've been hearing it, but that's really not the most important thing. So this is the dabrafenib trametinib trial, and it took an eternity to enroll. This trial opened globally. Okay, so we had patients from Asia. 44% were from Asia. We had patients from the Netherlands and the United States. And even then, it took 4 years to enroll 36 patients. Wow, I know. And what an amazing amount of money was poured into this trial. But the great thing is that we had great responses, and this drug was approved for BRAF mutated anaplastic thyroid cancer in 2018. And so we recently published what the median overall survival was for this group of patients. It was 14 and a half months. So who wants to just live 1 year plus in change? Right? Nobody's raising their hand. We want to live longer. We want to get lots of life out of this. So, what happens here? At 6 months, we start losing patients. You see how it drops dramatically at 6 months. So what's happening here? And, how can we keep this tail up here? We want a tail that goes across up here, right? Not down here. So how do we raise that tail is the question. And so you have to understand what's going on. Why do we lose patients? Why do they progress at 6 months? Why do they die? It's basically because these tumors, even though they have this really great initial response, many times what happens is that, so this is a patient where you can see the tumor here goes away, starts to come back, and now it's roaring back, right? And we took this tumor out. And what you see here is, it's too small for you to see, but this patient here had a BRAF mutation and a couple other mutations. The patient, same patient, we took this tumor out and we tested it, and now the patient has a BRAF mutation, but also has developed a KRAS mutation. And KRAS mutations, we don't have any good therapies for right now. So now you're dealing with a tumor that is only the cells that have the BRAF are responding to the drug, and then the ones that have the KRAS are no longer responding. So if you understand what's happening with the tumor, you can try and figure out how to manage this, right? And this happens pretty quickly in anaplastic thyroid cancer, very slowly in papillary thyroid cancer on BRAF inhibitors. So there are 2 strategies that you can do to avoid resistance. We call that resistance because you're resistant to the drug now. You can either take that tumor out before it bites you in the butt, right? Or you can add immunotherapy. All right. So we're going to go over those 2 things. So that's called neoadjuvant. A lot of people have talked to you about it already. Neoadjuvant is where you treat the tumor up front with something and then make it small enough so you can take it out and do a better surgery, right? Because we don't want incomplete surgeries. We want to try and get as much tumor with nice margins out. And so this is the current strategy for patients not only that have 4B disease, right? 4B is confined to the neck with a BRAF mutation, but also for 4C patients with a BRAF mutation. We put them on the drug, the tumor shrinks, and then we take this tumor out. Okay, so you've already seen this data with other people who've presented here, but this is our data looking back at our patients that we've treated with this strategy. And we present here 3 different patients. There were patients who had the neoadjuvant strategy, the drugs, the BRAF inhibitor with surgery, the ones that never had surgery but were on a BRAF MEK inhibitor, right? And then there are patients that had the surgery first before they went on the BRAF MEK inhibitor, but everybody got the drugs here. And, oh, you want to move that? Yes. Oh, thank you. Smart. It's really good to bring your fellows with you because they take good care of you. So the top line, this is where everyone wants to be at the top here, right? Did the best. And that's the one that had the chemo drugs first and then the surgery. And the other ones didn't do as well. So this was one way of raising the tail. We call that, want to keep that tail way up there, right? The guidelines do kind of recommend that. What they say is that if you have an unresectable 4B, remember I said we do this for 4B and 4C, and where radiation is feasible, then you do that. Or you can do neoadjuvant, and we disagree with that. We think everybody should have neoadjuvant because they do better. And we think that this applies to 4C also. The other strategy is adding immunotherapy. And you already heard a little bit about immunotherapy. This is a study that was done also globally. This study enrolled, I think, 45 patients or so. And what they saw was that the median overall survival was about 6 months. This is with just being on immunotherapy, right? So, I mean, it represents some progress. Some patients do well, and you see that this tail stays really high in some patients. In the patients that have this expression of PD-L1 that we talked a little bit about this morning, but we can do better than that. So there is a mouse model of anaplastic thyroid cancer that has a BRAF mutation, and in the mice, when you gave the mice, not the patient, the mice patient, the mouse patient, if you gave them just the immunotherapy, that this is their thyroid tumor here, okay? It looks pretty much the same, right? As control means they didn't get anything. And then if you give them a BRAF inhibitor, it gets smaller, but it doesn't go all the way, right? It doesn't go away all the way. And then if you add the immunotherapy, so the combination with the BRAF inhibitor and immunotherapy had the best shrinkage in the mouse model. Okay. So we designed a study. At the time that we designed this study, dabrafenib and trametinib were not approved for anaplastic thyroid cancer. And so the drug company did not want to give us the drug to do this study with dabrafenib and trametinib immunotherapy, but we had another drug company who did want to do a study in anaplastic. And so we designed it we basically divided patients by their mutation, what we call a driver mutation. So whether you had a BRAF mutation, whether you had a RAS mutation, NF1, or if you didn't have any of those, then everybody would get immunotherapy, but you would get a targeted therapy that matched your tumor mutation. Okay. And in a nutshell, I'm not going to go over all of this. I know you want to know who these people are. But this is just the ones with the BRAF mutation, but you see that the response rate is higher. Remember, with dabrafenib and trametinib, it was only about 50%, 56, 55%. Overall response rate was higher, 72%, but also the tail is much higher than with the dabrafenib and trametinib, which so at 2 years, 32% were alive. At 2 years, 67% alive with immunotherapy, 67% were alive at 2 years, whereas with dabrafenib and trametinib, only 32%. And so this is now part of our algorithm. You don't need to read this, but basically it's very complicated. Okay, because we want all BRAF mutated patients to see dabrafenib trametinib up front. Same thing with the 4C patients. And then we want to consider taking these tumors out from all of these patients. And we also use immunotherapy because we don't want them, while we're waiting to operate on them, we don't want their tumors to grow again, and then we can't take out their tumor, right? So we use that strategy as kind of a four-pronged strategy. You do the two chemotherapy drugs, you do the immunotherapy, and then you operate on them. And then we oftentimes leave them on all these drugs, although we're starting to consider like maybe we should take some patients off. And some of you have already come off of at least immunotherapy. So, okay, so what about the rest of the patients? It's about 60% of patients that don't have a BRAF mutation, and we need to know what to do with them. And this, I think we just ignore it because I don't agree with any of it. Okay. So I know I was on the guidelines committee, but they don't all listen to me. So anyway, when we look at lenvatinib in ATC as a single agent, this is a drug that's approved for differentiated thyroid cancer, doesn't work very well. Okay, we don't need to look at this for too long. Patients don't live very long, about 3 months, and that's it. And so I'm not sure why. Oh, yes. Now I know the point of this next slide. For fusion patients, right? So patients that we talked about this morning that have an NTRK, RET, ALK, also BRAF fusion, which is different from a BRAF mutation and is treated differently. These are very rare. Basically, we have very little data, which I know you can't see, and I'm sorry about that, but the data that we have in anaplastic is very limited, very few patients, 29% response rates with NTRK inhibitors. And then here we just had like 2 patients and one of them responded with a RET inhibitor. So we don't think that single agent drugs for anaplastic thyroid cancer make sense. And so we don't really do that at MD Anderson, but it is in the guidelines. Okay, so what do we do? There was this trial with lenvatinib plus pembrolizumab, so combining targeted therapy with immunotherapy, and the responses were really good. This was done in Germany, so I do not know who that first patient is, so don't ask me. This is a German trial, and we see that no complete responses, but 52% partial responses, which was pretty good. And when you compare it to single agent lenvatinib, where the tail really drops off, right? This looks a little bit better. It's not great, but it's better. And so, you know, we think that combining targeted therapy with immunotherapy is the best strategy, but we need better solutions. So what can we do? Because lenvatinib pembrolizumab is pretty good for some patients. It works well in some patients, but really the problem with lenvatinib pembrolizumab is that the lenvatinib is not a drug that we can give all patients, because you can have bleeding events with lenvatinib, and a lot of anaplastic patients have a lot of problems with these tumors causing bleeding. And so you don't want to give them a drug that's going to make that worse. And so not everybody can take lenvatinib pembro. It also doesn't work for everybody. We don't really understand why. So what are we working on now? You don't need to understand this slide. I put it up there really for my own benefit to tell you that we have a lot of patients that have not only BRAF mutations, but also RAS mutations. So believe it or not, there are all these different types, classes, what we call classes of BRAF alterations. So we have the BRAF mutations, which is what most anaplastics have. We have BRAF fusions, which is very rare. And then we have these class 3 BRAF, which means it's a mutation that's not V600E. They're usually like, I can't remember the numbers, 500 something. We don't really see it a lot in ATC. And then we have a quarter of patients that have RAS mutations. So 40% here, a tiny few patients here, and then a quarter of patients here. So if we could find a drug that targets all of these, wouldn't that be great? I mean, that really increases the numbers of patients that maybe could then go on to have surgery to remove these tumors, like we did with the BRAF. And so this is being worked on right now. We have a lot of different inhibitors, and I just put in a general class of pan-RAF inhibitors, but Dr. Hamidi talked a little bit about also the patients who no longer are responding to dabrafenib trametinib and adding a third drug by a group called a company called Thrive. I didn't want to really go over because she was going over all the trials, but we now have a lot of clinical trials for ATC, and they're starting to come online. And we have a pan-RAF inhibitor. We have a couple of pan-RAF inhibitor trials now for thyroid. There are more trials that are coming next year, and so that's really kind of the more exciting stuff. And then we have the CAR-Ts, which I am also not really going to go into because we've talked about them in other sessions, but CAR T cells is essentially just taking the patient's own cells and engineering them, training them, and putting them back into the patient. So right now, so this list changes so much, which is why I don't love to put up these lists, but you can just go to clinicaltrials.gov. You can select anaplastic, you can write in anaplastic thyroid cancer. You can say on there that you only want, trials that are in the United States and only trials that are actively accruing. And then you can see which are the studies. And if you click on them, you can see where where you can go or who you can contact to find out more about the trial. Okay, so this is, I'm just wrapping it up here with the picture of our FAST team. This is this is now kind of an old slide because we have some new people that aren't on here, but it really takes a very large team to manage anaplastic patients because they're very complex, lots of moving parts, lots of other medical problems that they have. And so we really need a lot of people working on this. We have our translational team that gathers tumors that come out from surgery, for example, trying to grow them in the lab and then put them into a mouse to make a mouse model and see what drugs work on those. And so, we're really trying to make more of a dent in the survival of anaplastic patients through this. And the way that we do that really is through funding these studies. And so we've been really very fortunate at MD Anderson to have a lot of funding for anaplastic thyroid cancer. I can't tell you, 10 years ago, there was nobody who wanted to fund anaplastic thyroid cancer because they're like, that's hopeless. Why would we give you money for that? And now there's a lot of interest. In fact, we have maybe too many trials for anaplastic patients because we don't have enough patients to fill those trials. But the dinner tonight to raise funds for thyroid cancer is really important because this is how we make progress, right? And you may have heard about ITOG also. It's also trying to advance the field in all types of thyroid cancer. And so anyway, we thank you for being here. And I have to I'm just so amazed at how many anaplastic patients are here this year. I can't tell you how sad it was to stand up here and talk about anaplastic a decade ago when we were like, maybe 3 people in the room and one of them had anaplastic. So this is truly amazing. I thank you so much for coming here and showing everybody that, this is something that you can survive. We can't save everybody, but we are really trying hard. Thank you. Anybody have questions in the room? And then we can get to the online. No?
I was going to ask if you could redo the A, B, C, like the slide. There was the pop-up on the bottom of the slide, and I was trying to figure out what I was.
Oh, sure. I'll put that back up. Okay. So you have to understand that ATC, let me see, it might be faster for me to do this. Oh, no, it's not faster. What did I do? I stopped sharing. I think by now I know how to do this and give enough virtual talks. Okay, so 4A is the one where I told you, it's kind of after the surgery, you realize that the patient has anaplastic because those are inside the thyroid, and you rarely diagnose those beforehand. 4B is a patient that just has tumor in the neck, but it's left the thyroid gland. So this is the thyroid tumor, and it's extended out here into lymph nodes, but they don't have any disease outside of the neck. And then 4C are patients that have the disease in the neck, and then they have it outside of the neck. That's how you present. That may not be your story 6 months later, right? Because maybe you've taken it out and there's no evidence of disease, but you still were 4B. Okay. So that just tells us at the time of presentation, what is your risk of dying of anaplastic thyroid cancer? That's what it tells you. Yes.
I think I might have misunderstood. Do all patients with an NRAS mutation, but not anaplastic, poorly differentiated, does that mean that it started as follicular and not papillary?
That's a very good question. We see RAS mutations in both papillary and in follicular thyroid cancer. It's just more common in follicular thyroid cancer. So I was just really kind of giving an example to not confuse people. But yes, you can have a papillary thyroid cancer that has a RAS mutation that, becomes poorly differentiated or anaplastic.
And just a quick second one. Do most of the clinical trials that are going on right now for anaplastic, do they also allow poorly differentiated people in?
Some of them do. Okay. So the CAR T trial, for example, allows poorly differentiated, and we're actually trying to expand it to other thyroid cancers, not medullary, but to not medullary, but to the, to all types of the non-medullary thyroid cancers. Hopefully we can do that. Some of these trials allow poorly differentiated, like the one that I showed you that had all the different arms with the BRAF and the RAS, and that's already finished, but that one allowed poorly differentiated. So you have to look and see on clinicaltrials.gov, it will tell you.
What about that? Any trial? No. He's worried that autoimmune disease, because he has like super controlled ulcerative colitis. But at one point when we were looking at a clinical trial out of Sloan, at first his oncologist said, "Oh, I think you'll like this one." And then it was like, next because of that.
Right. So most of the trials with immunotherapy, because we didn't talk about side effects, but immunotherapy can cause you to have pretty much an inflammation of any of your organs. And so if you already have a disease that causes inflammation of an organ, like ulcerative colitis, then they exclude patients like that, usually, not always. But yeah, I mean, the ones that are gut related, they usually exclude them because you can, have like a hole in your intestines if you get worsening inflammation from the immunotherapy. So there are exclusions, and they're all listed in clinicaltrials.gov. You can just read through them.
Thanks for the great talk. You mentioned there was an animal model that's being used for some of the preclinical development. I'm assuming that that's an orthotopic injection of the cells. And if so, can you do any of the work that is involving the immunotherapy in those kind of animals? Because I'm also assuming they're probably athymic animals.
The one that I showed you was actually immune competent. Yes. So it's important if you're going to be doing immunotherapy trials, or I guess trials on mice, then they have to be, an immunocompetent mouse. So yes, I mean, these are, well-designed studies that account for that. Yes.
Not so biologic question from the wife of a biologist. So I went to clinicaltrials.gov, looked for active studies in Canada, 0, active studies in Mexico, 0. But I know that the International Thyroid Oncology Group includes University of Toronto. What are we, AKA you, doing to allow Canadians or Mexicans, use United States of America partners to come, and then how can my husband join a clinical trial and not become broke and destitute?
This is a huge problem. We're actually working on it. But I have no, I have no sway over the insurance problems of all of our countries. So, when you enroll in a clinical trial, your insurance has to allow you to be on the trial because they're paying for a lot of things on that trial. They may not be paying for the drugs that you're getting, but they're paying for a lot of stuff, and it's very expensive. So, obviously you can pay for that yourself if you wanted to, but like you said, you might become destitute. So our solution, what we're working on currently, Dr. Iyer is opening what we call a master observational trial. It may or may not help, right? It's not a great solution, but it's something. But what we want to do is, instead of, not everybody can come to see us, or even to the United States. So how do we help physicians in other countries, or even in our own country, but they just can't come to see an anaplastic expert? How can we help them do what we're doing at MD Anderson? And so we've created this master observational trial that we're trying to get funding for, where we tell them, we give them the algorithms, we have meetings, and we kind of guide them on how to manage certain patients and how to evaluate them, what to do if the drugs stop working, right? And then what we get in return is data, right? Because data is gold. You see that we have a trial here with 36 patients. Usually cancer trials have hundreds of patients. And there are hundreds, thousands of anaplastic patients. They just can't come and participate in a trial. So that's one solution, but it doesn't account for the fact that you may not have access to some of the drugs, that's a problem. But we're trying to get creative. This is the best solution we have at the moment.
Can you put us on the list?
Yes, we will. We will. We're starting with the US, but then we're going to expand it out to North America, South America. We don't have anybody in Mexico, unfortunately, at the moment. We have some partners in other countries in Europe and Asia. Anyone else in-house? No. Okay. You want to do some questions? Sure.
We have a question from Mike online. What about Keytruda therapy only after 1 year of dabrafenib and trametinib no longer working and post-tumor removal? I just started in a trial in this scenario, ?
Just starting. Okay, so my understanding is that this gentleman was on dabrafenib and trametinib. It stopped working, and yeah, why don't we have him clarify? Because what I'm not clear about is whether the dabrafenib and trametinib is still being taken, or was that dropped and replaced with the immunotherapy?
Mike, you can online, Mike Thompson, if you want to turn on your mic, you can speak and clarify your question.
Okay, well,
Okay, I guess I'm unmuted now. Can you hear me?
yes.
Yes, I was on dabrafenib and trametinib for stage 4C, and I was tested for BRAF really quick, and that medicine worked really good. I just went on those 2 drugs, and almost everything cleared up. I had multiple mets to the lungs, and those almost all cleared up. Everything looked really good, and just about at a year, they realized they could take the tumor out, which originally they thought they couldn't on 1/2 of my thyroid. But now it's been about 6 months since the surgery, and it started growing again just in the surgery bed and on the other side of my neck. And but just in the last month, I became diabetic. My blood sugars just started going through the roof. So my doctor thought it would be best to stop the dabrafenib and trametinib because it didn't seem to be working anymore. And I just started on a Keytruda only trial after only having my first dose. But you talked earlier about using dabrafenib and trametinib and Keytruda all at the same time. I guess this is a little different.
Right.
They didn't stop it before something popped up. And now this is seems to be, according to my doctor, the only way forward. And I've only had my first dose 2 weeks ago but it seems to me, from what I feel on my neck, that the tumors are already decreasing in size somewhat, but we have just started. So,
Okay. Yeah. So, what we would usually do is not stop the dabrafenib trametinib. We add drugs to the BRAF inhibitor, because when we stop the BRAF inhibitor, usually things get worse. Now, that may not be your case, right? But we usually add therapy, not we try not to stop the BRAF inhibitor. And so, but if the thing is that if your disease is confined to your neck, why don't they just give you radiation? Or
it's not.
or it's not confined to your neck. Okay.
Well, no,
It's just
basically it's in the lymph nodes in the chest, and it went into all the parts of my lungs. But the original medicine has pretty much made most of that, so it's not. Right now, the only active disease seems to be in my neck, but it's in the chest. And they said, not the chest, in the lymph nodes, around the esophagus and whatnot. And they said it was too many places. They thought that they could treat it all with radiation.
Okay, yes,
or surgery.
That is correct.
Yeah.
So you're on this trial. I would say to just quickly do a restaging, which means to, do scans. I would probably not wait more than 4 weeks to do scans, even though if the trial says to wait 8 weeks, I would do them at 4 weeks to see if you're responding or not, and then make a decision on whether you should continue or come off the trial. And if you came off the trial, I would recommend that you go on a BRAF inhibitor. We can talk about which one, in addition to the immunotherapy. So it sounds like you might have developed diabetes from the dabrafenib. Is that what they're thinking?
I think so. And he was trying to weigh, is the dabrafenib and the trametinib or whatever, the combination of the two, or maybe it's mostly dabrafenib. He had decreased the dose of the dabrafenib slightly for a while, and then it just, I pushed to get back in because I could tell on the other side of my neck that things were just like they were early on, like growing quickly.
Yeah.
And
so we just basically treat through that. I mean, we treat with, if you have to go on insulin or
and I'm on insulin now, but I guess I see my doctor again in 2 days. This would be I'm supposed to do one infusion every 3 weeks. I've had my first one. I go back in for my second infusion in 2 days, but I'm not scheduled for my first CT since I started the treatment until three more weeks, as opposed to, like you said, this would be week 3 where I'm going in tomorrow or on Monday.
Yes. So, I mean, I think that if it's not working, then you probably need to go back on a BRAF inhibitor. And if the concern is that they can't manage your diabetes, I mean, if an endocrinologist can't not my type of endocrinology, but like a regular endocrinologist can't manage your diabetes, there are BRAF inhibitors that cause less of this problem. So I had one patient that she really had, she had pretty bad diabetes on the dabrafenib, and she was unwilling to take insulin. And the oral medications that we could give her just weren't enough. And so what we did is we switched her to another BRAF MEK inhibitor called encorafenib binimetinib. The trade names are Braftovi, Mektovi. And she hasn't had problems with the diabetes anymore. It just went away. So there are other drugs that cause less of this problem with the high blood sugar. So you could consider that.
I think he did do some more genetic testing, which we hadn't had the results back yet. So I don't know if that might be part of trying to figure out if my mutation has changed from being primarily BRAF. But
Yeah, but it's always going to have a BRAF mutation.
Yeah.
It might have developed another mutation, but that BRAF is still needed because the cells still have a BRAF mutation.
Yeah. Okay. Well, that's good information to know. So in your experience, basically you want to try to stay on, and I can work with the endocrinologist as long as the diabetes, if we can control that without it getting out of control, it's better to stay on that than to just stop that for
Right.
a reason like that,
Yes, then we have a question from Jillian. Do all BRAF positive patients have a background of papillary thyroid cancer, or can anyone be BRAF positive?
Well, that's one of the clues that it tips us off to the patient having a BRAF mutation is when you see papillary with the anaplastic in the same pathology specimen, that's a clue that the patient could have a BRAF mutation. But you don't always see that. Sometimes all you see is anaplastic. There's no more, differentiated thyroid cancer in the specimen. So you don't always see that papillary thyroid cancer there.
Paul asks, I noticed that most of the trials exclude patients with heart disease. What are the immunotherapy risks for these patients?
Yeah, the trials oftentimes exclude patients who have like congestive heart failure or a recent heart attack, but not heart disease in general. And heart disease in general can be a lot of things. So if you're, if the heart function on an echocardiogram looks okay, sometimes we use a MUGA scan instead, which is a nuclear medicine scan, because they get a little bit higher numbers on the ejection fraction that you need to get into the trial. So you have to know all these little tricks. Then you would qualify if you're above a certain, it's usually like 55%. And then if you've had a heart attack within the past 6 months, they usually do exclude you, but not always. So it just depends on the scenario. But when we design these trials at MD Anderson, we try and not exclude these very common things, right? If you're in your 50s and 60s and 70s, you probably do have some heart disease, and that shouldn't exclude you from getting a treatment for anaplastic thyroid cancer. So we need to also just be cognizant of how we design these trials and not, we have very few anaplastic patients, thankfully, but we don't want to exclude, most of them from the trials as it doesn't make sense. And then we can't, and then then it's not generalizable, meaning that you might see something in the trials because you included only the best patients, right? The patients that could swallow, the patients that could, do everything they were doing before they got sick. And then you put those into a trial, and then you get all these great results, and then you try it in patients, what I call normal patients, right? Who have heart disease, who can't swallow pills, who maybe have declined in terms of what they're able to do to care for themselves because of the disease. And you try it on them, and then it doesn't work. So, then you've wasted your time with these trials when you can't use it on the majority of patients. So we also just need to make some rational decisions on who we're going to enroll on trials. Okay, that's it. Anyone in-house have a question before we go? I think we're out of time. Oh. No pressure.
I like asking questions. Speaking of anaplastic thyroid cancer only, what worries you?
Oh my goodness. A lot of things. Have you seen the bags under my eyes? I dye the grays. Where do I start? I mean, the patients that, it's very rare, but there are some BRAF mutated patients that don't respond to therapy, and those really keep me up at night. There are the patients that don't have any targets. We don't have any good therapies. They can't go on lenvatinib, they can't go on pembrolizumab, and like, what do we do for these patients? So we're really, and then we have trials, but oftentimes, like I said, patients don't qualify for the trial, maybe because they live in Europe and they don't have medical insurance here. And how are they going to pay for all of that? It's a lot. It's a lot of problems that we have. And it's based on the fact that that our insurance situation in all of our countries is just crazy. It's based on the fact that patients sometimes, when they come, they're like really, really, really sick. And I can't give treatment to all of those patients. If they're so sick that they can't get out of bed, they're not going to do well. And I'm just making the situation worse. So these are the things that keep me up at night. There's a whole nother list of them I can tell you about, but I won't bore you. The ATC, right?
I think I had a bad dream about one of our patients the other night, but for the life of me, I can't remember who it was, but it was a specific patient that I woke up thinking about that patient.
Yeah, some nights we don't sleep. Christina Bouie's my nurse practitioner. So she's my right hand woman. And so yeah, we deal with a lot of really advanced tumors and very sick patients. So yeah, it's good to know it keeps you up at night too. I'm not alone. I'll call you up.
Dr. Cabanillas, we had another question come. It's, hi, Dr. Cabanillas. It's Rebecca. Is ATC hereditary?
So that's a good question. So I would say in general, it's not hereditary, but there are forms of differentiated thyroid cancer that are hereditary. They're rare. I think there was a session here about it. There might have been a session, right? Does that sound familiar about Cowdens and stuff like that? Yeah, I think there was a session, but anyway, maybe I'm confusing it with American Thyroid Association. And yeah, I'm getting my meetings mixed up. But there could be a genetic component. We have seen, this would be extremely rare. We have seen patients where there have been like a mother-daughter who've had anaplastic, which is really weird. And yeah, so you wonder if there is something genetic. We send those patients to our genetic counselor to see if, to just do genetic testing to see if we can find a mutation that might be causing the thyroid cancer. And there's a lot that we don't know about the genetics of thyroid cancer in terms of the hereditary components of it. But the majority of these tumors are not hereditary. If you're worried about it, like you have a family that has multiple generations that have a papillary or anaplastic thyroid cancer, then, you can, what we recommend is that the children of those individuals start testing about 10 years before the diagnosis in their parent, right? So if their parent was 50, then the children start testing at 40, like doing ultrasounds. For anaplastic, that might be, it might be best to, do it even earlier. I don't know. We don't have very much experience with this. It's a good question, but it's so rare. I think it's going to be difficult to really know. But if I'm worried about a genetic component, I'll send them to my genetic counselor. Oh, we got a question here.
I just want to outline how amazing you guys are and the fact that you sacrifice your sleep for our loved ones. Thank you for that. But my question is, yeah, let's clap for them. I mean, it's huge. The nights of lost sleep we could never repay with gratitude. But where does microscopic focus of anaplastic fall in this, and how do you approach that?
That is such a good question. So what Angelique is talking about, yes, what Angelique is asking is, what do you do with a tumor that has, let's say it's poorly differentiated or papillary, but it just has a little bit of anaplastic in it. So sometimes the pathologist will read the pathology and say, this is papillary thyroid cancer and it's 5 centimeters. And then there's 1% or 2% or 5% of anaplastic in it. So that basically that's transforming, that tumor is starting to become anaplastic. And we treat those patients, even if they have just microscopic anaplastic, as an anaplastic thyroid cancer. So if we took it out and we see that microscopic anaplastic, we would give them chemoradiation to the neck. Those usually haven't left the neck. So you're usually dealing with a 4B patient, but we would treat them as if they had, a much larger anaplastic thyroid cancer. And the reason is that if you think about anaplastic being the end stage of a papillary thyroid cancer, let's say, or a follicular thyroid cancer, or HERTHL, which is now called oncocytic, the process is that the tumor has to acquire more and more aggressive mutations along the way. And if that mutation is in the anaplastic, it's probably already in the papillary too, at least some of those mutations. And so that's the way I think about it, but we haven't really done enough studies to know if that's, the appropriate thing, but that's what we do. We treat them as if they have anaplastic thyroid cancer. Yeah. It's a good question. She's a doctor though, so she has, the doctor question. And then we have our biologist here. A cancer researcher. Great questions. Anyone else? All good? All right.
We
See you at the
have-
dinner.
We have a lot of thank yous.
We have more?
No, just thank yous for all you do.
Oh, thank yous. Okay. Yes. Thanks for coming, guys. Hopefully I'll see you all at the dinner.